Shall I go? Okay. So, hi, morning and afternoon, whatever it is. And so today the idea was to share some ideas about how merit can be used also from an integrative perspective, and so how we can combine some external components with merit in order to widen the applications of merit. So Libby is going to present something about psychoeducation. I would like to introduce some things I've tried to do in order to use compassion-focused practices in treating, generally speaking, cluster A personality disorder. I would focus today more on just two cases. There are two clients diagnosed with schizoid personality disorder. So the idea of these attempts were just to integrate a component, an external component, these experiential practices derived from mindful compassion, compassion-focused therapy, and so on, within the context of a merit intervention. The rationale of doing that, it's, I would say, quite consistent on what we know, even if there on the two cases I'm going to present that are schizoid personality disorder are really, it's really an understudy area, both the psychopathology and psychotherapy. But there are several papers published by the team of Paul or other teams, especially in the UK, I would say in Scotland, where they have suggested how there is an intertwined link connection between what we define as metacognition, what we can define as compassion, or more generally speaking, substituting or the capacity to substitute. So the idea is that on the one hand, we know in this group quite extensively how metacognition is a complex, integrated, nuanced way to integrate my understanding of the mental states of myself and the other. And on the other hand, compassion is usually defined as a twofold construct. On the one hand, we have the form of awareness. I'm aware of my own and other sufferings, but this awareness is coupled with a motivation, an intent. That is I am motivated, I would like to alleviate the suffering. Again, both the one of mine and the one of the others. So several studies, again, as I was mentioning, from US teams or the UK, European teams, we conducted a study at our center in Florence, are showing how there is an intertwined dynamics between the capacity to understand our experience, so to use our metacognitive skills, and the capacity to recognize and soothe our suffering. For example, in a study we published last year, we show how a high level of severe form of self-criticism in the form of hating oneself. So I hate myself, I consider myself as disgusting. This construct, this process of self-criticism was moderating the relationship between self-reflectivity and delusional ideation. So the idea is that the higher the self-criticism, the lower is the association between metacognition, broadly speaking, and the risk for severe psychopathology. This study has been extensively published in the area of both positive and negative symptoms. So the idea is that it's quite easy to understand. If I perceive a lack of safeness, both at the interpersonal level in the form of hating myself, perceiving myself as totally inadequate or even disgusting because, I don't know, I have odd beliefs, I have strange ideas about the world, or a lack of safeness in the subjective world. So I perceive the other as judging me as inadequate. I perceive the stigma of being diagnosed with severe mental disorders. These processes impair significantly the capacity to use metacognition. And so the idea, this attempt to integrate merit with this experiential practice is that there is a vicious cycle between an impaired capacity to use metacognition and impaired capacity to soothe one's own suffering. So, as you know, in merit, for example, we use the insertion of therapist's mind, the therapeutic relations as a way to reduce this lack of safeness, promote a healthy therapeutic relationship, and so this is the context, a safe context for increasing self-reflectivity. An alternative way is to use some experiential practice. So some techniques that are rooted in the tradition of mindfulness and similar approaches in order to reduce the arousal, and so having a more easy way to access metacognition. In the case series, I'm going to briefly summarize. We try to maintain the pivotal rationale of merit. It is the idea that we try to use techniques that are tactics, therapeutic tactics that are consistent with the level of metacognitive functioning of the client. This means, for example, that you don't use an experiential techniques aimed at increasing the capacity to label an emotion with a client having very low self-reflectivity. You don't use an imagery technique about an interpersonal encounter with a client that is lacking a decent level, a minimum level of, I don't know, awareness of the other's mind. So the idea is these experiential techniques may be, using Bruner's word, something like a scaffold to better work on metacognition as we usually do using merit. For example, in these two clients, I'm going to briefly summarize, they were diagnosed with schizoid personality disorders. In the early phases of the intervention, I'm talking about the first month, so the first 6 session, we just introduced 1-2 simple techniques, such as grounding. I don't know if you're familiar with. Grounding is a very basic technique. You ask the people to enter in contact with some perceptual component of their life, such as, I don't know, asking people to focus on the foots on the ground, on the parts of your body that are in contact with the external world. Or we use some very simple soothing breathing techniques. So it's just the traditional mindfulness exercise where you suggest the person to focus on the breath and so on the changes of your body while breathing. And once we, using elements of merit, we increase the capacity to mentalize clients' own mental states and the one of the other, we started using some more complex techniques, such as techniques aimed at increasing the experiential acceptance of one's own mental states, experienced emotions, and so on. And then in later stages, later phases of the intervention, while the client was capable of not simply understanding his own or her own mental state, we asked, but also to be capable, to understand the mental states of the person in front of him or her. We tried some more complex techniques where the aim is to not simply experience how do you feel when thinking about yourself, but also about the other or about a specific intersubjective event episode. So this just to summarize what we started from, what we are trying to, and I don't know, because if you agree, maybe the easiest way to, I don't know if you are familiar with this kind of techniques, compassion focused therapy or mindful compassion. It's a question.
Maybe for share a few words for those who don't.
No, because an alternative would be to try something. It's easier, more concrete, rather than talking, since I have a terrible English accent. So we can just try a practice. So if you agree, I will kindly ask you to follow me in a very brief exercise. It is, I would say, an intermediate exercise, because in an exercise where you ask the client to label the emotion. So you need a client having a decent level of self-reflectivity and a decent level of the centering, otherwise it's useless. But this is a compassion-focused practice. So during the exercise, I do it very shorter in order to just to experiment and then talk about. The aim usually is longer than in the way that I'm going to present now, but the goal is usually to ask the client to recall an episode where they experience a negative feeling and try to label, to give a name. The name, as you're going to see listening to me, can be a standard label, such as, I don't know, sadness, or an invented one. So letting the people being free, especially those who may have problem in mentalizing their own mental states. Okay, so if you're okay, you can just start by finding quite comfortable posture, not the perfect one because it doesn't exist, just the posture that can help you trying to do this exercise. And if it does work for you, you may close your eyes. Otherwise, you can just look in front of you. And we can just start by focusing on the parts of our body that are in contact with the external world. It can be the foot on the ground or the body on the chair. Observing how it is to perceive how the gravity locates ourselves here now in the place we are. Then maybe you can try to focus on your breath, on the constant and sometimes soothing rhythm of the air breathing in and the air breathing out. Observing how your body changes while the air breathing in and then breathing out. And if you are distracted by a sound, noise, or a thought, it's okay. It's the normal way your brain works. You can just observe this sound or thought, let it go, and come back to your breath. Now, I would like to ask you to focus, to recall negative emotions you experienced recently. And just try to envision, to recall the context where you experienced this negative emotion. The place, colors, sound. And try to give a name, to label this emotion. It can be a usual name, such as sadness or anger, or an invented one that you can create to summarize what you felt. And try to repeat a few times in your mind this label. This is sadness. This is anger. Now let this emotion flow away and clean your dashboard. And try to focus back on your breath, on the constant and soothing rhythm of the air breathing in and the air breathing out. If something distracts you, it's okay. It's the normal way your mind works. You can focus back on the air breathing in and the air breathing out. I ask you to focus back on that negative emotion and try to locate the place in your body where was and maybe is more present, where you feel that feeling, either sadness, anger, or what it was. And you may put your hand on this part of the body, can be the stomach, the chest. Just appreciate for a while the contact of your hand on your body on this part where you felt this emotion. Observing how it is, this contact on this part of your body. Having just a moment to take care of this part and of this emotion. And before concluding the exercise, just try to expand this caring attitude to all your body and your experience. When you feel comfortable, open your eyes and conclude the exercise. Okay. I don't know if someone want to share something about the exercise, how it was, boring, annoying, quite usual at first when we try, or I was listening to me, or single parts of the exercise. Any comments?
I felt the effect of regulation.
Sorry?
I had the effect of regulation, emotion regulation. Really, it did something in the way I experienced the emotion.
You notice specific sensation while recalling the emotions or while using the hand, touch the part. As I mentioned, since I don't want to waste time and let Libby talk later after me, the aim of this exercise is to promote a sort of experiential acceptance. If you think back about the single phases of the exercise, in the first part, we try to initiate the process by focusing back on the soothing breathing. And obviously, as I said, we arrived to this kind of exercise after having presented simple techniques such as focusing on the breath. So the client know what does mean focusing on the breath. It's not something that arrived randomly. And the other two parts that are important, at least in my experience with the client with severe mental disorders, is the first one of trying to label the emotions. It's alexithymia is a very common component of experience of our clients, and the difficulty in labeling or recalling it's quite common. So integrating dialogical narrative techniques with this experiential can be useful, not with anyone, but with many clients. And the last part is to use the body, such as in this case the hand, to try to activate a stance that would be similar to what I was presenting theoretically before as compassion. So to promote something different, because usually clients with severe mental disorders, they perceive their inner experience as threatening. So they reject them, they don't want to talk about, they don't want to think about. So sometimes having some experiential strategy may be very helpful. Coming back to the two clients I was referring to, and I used extensively this practice where they are diagnosed with schizoid personality disorder, so we're presenting recurring negative symptoms. And so the conceptualization we used in treating with this client was based on the idea that these negative symptoms, this form of detachment using personality words, was a sort of an extreme defense against the perception of a word as threatening, and also to an inner experience of themselves trying to understand the word as threatening. And so the flat emotion, flat behaviors, and interpersonal, and not only, were, from this perspective, an attempt to defend themselves. And so offering a safe space that can be just exceeded using, as motivated, for example, in several parts of the manual of merit by using just a theoretical relation, but also sometimes using experiential technique can be very fruitful, can be very useful for them. So, and it's, I have also to say that in the early phase can be problematic to present this kind of intervention. And then it's important that when we present experiential technique, we present them and we have to be ready not to use them because the client may say, no, I'm not interested in. So it's important to present, ask if the client may be interested in. If they say yes, okay, we can do an attempt to go on. But it's very important, especially with those with severe symptoms, to explain how they can interrupt the practice in any moment. Because even if we are not, but frequently clients perceive ourselves as experts. So they may force themselves to do something that they dislike. So it's important always to do a lot of check and go about the perceived safeness of the therapeutic relationship. Okay, so if I remember well, we said about 30 minutes per presentation. So I will conclude and leave space to Libby, and eventually be happy to answer to questions.
I find myself wondering if patients who are more paranoid perceive this exercise in a different way.
Yes, I have used for presenting another single case the use of this kind of techniques. In my experience, I'm talking about paranoid personality disorders. It's quite common that the client have a interpersonal cycles where their schema is rooted in the idea that I innerly, deeply, covertly, I feel myself as inadequate, as potentially at risk while I'm meeting the others. So I have to defend myself and I have to protect this inadequate part of myself from the others. And so usually they reported, at least in my experience, a sense of threats that is usually related to an inner arousal state. And the risks are pretty similar of the one I presented about the previous case of schizoid. So to explain them and to be progressive in presenting these techniques. Again, because this client, I used these experiential techniques with and was diagnosed with paranoid personality disorder. We started with just simple grounding techniques, then the breathing system and breathing soothings techniques, and then we arrived to techniques such as the one I presented. And I guess that any intervention is potentially, possibly an alliance rupture. So it's important to present, explain what we are going to do, and ask the client to decide if he or she is interested in doing that, and explicitly giving the permission to interrupt the practice. That's, in my experience, usually happens, because even if the client says, no, this doesn't work for me, you have material to work from a therapeutic alliance perspective. So, and you're walking your talk, you're acting as you are saying. That is, it's the client deciding, you are not the expert, you're not deciding. So I don't know if I have answered back to your question.
You have.
Simone, if a client is somehow resistant or struggling to engage in the process, do you try to work through that, try to help to understand what the resistance is? Or
Yeah.
what's your thinking about that, and how do you manage that?
It happens many times, especially with the experiential techniques. So my idea is the client says no, it's no, but I'm interested about why he's saying no and how he's perceiving me asking him or her, because I'm interested in because I'm taking for granted that is a rupture in the alliance. So as Safran would say, the problem is not having the rupture, the problem is not discussing the rupture. So I just try to explore with the client the meaning of me asking that. And usually a lot of interaction things come out. And maybe we will never use an experiential technique again, but at least we know that the client does not want to use them. And usually things they have always experienced is that if you have this cautious and kind approach in presenting techniques, people appreciate, and it's a way to work on the therapeutic alliance. I guess it's the same if you ask people to, can you tell me about your childhood? It can be the same, can be very scary. Okay, just add just one final point that is more theoretically speaking, my sound hypothesis, I would call it sound hypothesis, that there are a lot of possible convergence between a metacognitive oriented approach and a compassion focused approach, because there is a similar idea of the how can I say the dance between client mental states and the mental state of the people surrounding. And so the importance of focusing on the therapeutic relationship, either you're using experiential techniques or more narrative techniques. And so a very destigmatizing approach to the pathology, in the sense that we are interested in how people might adapt or not to their psychological challenges, rather than talking about symptoms or diagnostic categories. And in this sense, the general constructs such as feeling threatened, feeling safe, feeling understood, they are common both in metacognition and compassion, are very useful, and in my experience, clinical experience, very welcome by the clients. So that's the reason I found so easy to match, to integrate these techniques into emergency intervention. Again, as we said, there are clients that are not interested in, but it's just a useful alternative from my perspective. And I was happily surprised by how these techniques works also with clients so attached, so flat, emotionally flat, such as, for example, client with a diagnosis of schizoid personality disorders. And interesting to see, in conclusion, how by being experiential techniques that you teach the client, and usually I give also either the recording of my voice or the text, if they prefer to record their own voice. It's something useful for their daily life, so to increase their recovery and their sense of independence and mastery in managing their daily challenges, even after the end of the intervention. Okay, so.
While listening to what you just said, I thought about a paper we have, Libby, from the baseline data of the trial, that we found an interaction between metacognition and self-compassion and outcome. So people who had higher self-compassion could use metacognition better, could benefit more from cognition.
For meaning in life, yeah.
Yeah.
Okay, so.
Yeah, if you're interested, I can share. Me and Nicola Petrocchi wrote a review about the physiological underpinning of this link between metacognition, perceived safeness, and capacity to mentalize.
First of all, this exercise really calmed me down, and it helped me before presenting. So thank you for that. And I'm still thinking about connections between his work and mine. And I think I will leave it for comments after I will present. I think I will start. Okay, so I have a presentation I want to share with you. I will just find it. Okay. Okay, now you see. Yeah. And so you see my presentation now? Okay. So hello, I'm very glad and excited to speak here, and I would like to open with a short video from the comedy special Look at You by Taylor Tomlinson, where she is a young comedian who describes here how did she learn about her diagnosis. Okay, so I also hope you'll be able to hear. Here.
I thought I was on an antidepressant. It turns out I'm not. It turns out I'm actually on a mood stabilizer that they use as an antidepressant. Fun fact about prescription drugs. Everything they prescribe, they actually use for like 4 different things. So you don't really know what your deal is until you find a combo that works and then Google all your pills by yourself. So after years of trial and error, I finally found a combination of things that worked for me. And 6 months ago, I decided to Google it, because what the hell? And it turns out that everything I'm taking is primarily used for bipolar disorder. So I went back to my psychiatrist and I was like, hey, do we think? And she was like, oh, yeah.
Okay, so what I want to say is that it seems that Taylor Tomlinson is not the only one who learned about her mental state in such an incidental way. In a recent study conducted in psychiatric ward in Israel, 86% of clients and their relatives reported they received the diagnosis by reading the release form or during an incidental encounter with the personnel. And I would like to suggest that receiving a diagnosis can be viewed as the starting point of broader processes of illness perception and personal narrative construction. So I think we should all keep in mind the fact that people who are diagnosed with schizophrenia often have limited information or stigmatizing ideas about their diagnosis. And I'm going to present a case report that was part of my PhD research project, the Merit RCT trial in Bar Ilan University, under the supervision of Professor Ilanit Khasson-Otayon and with the collaboration of Professor Paul Isaker. And so this study sought to explore whether integrating psychoeducation into Merit might address some of the core issues related to people's need to know and understand the meaning of their diagnosis and integrate it into the personal narrative. Okay, so we begin with the client's background. She was a single female in her early 30s, a bit older, diagnosed with paranoid schizophrenia. During her mid-20s, she broke off her engagement with a controlling, aggressive, and humiliating person. And soon after, she began to hear disturbing voices warning her to beware of her family. She learned about her diagnosis by reading her medication prescription, okay? Only then, after her first hospitalization. And so her knowledge about her diagnosis remained very limited due to personal and cultural barriers. And what she did is that she Googled the term schizophrenia in order to learn more about it. And as you may guess, it did not give her a safe or sensitive environment or any dialogue about her condition and her experiences. And so what we did with my client, and after several weeks in therapy, she began a session with the words, "I wish I could make my life more interesting." And in the following dialogue, it can be seen how Emma reflects with me on her wish to learn more about her diagnosis and the way different people cope with it in order to create a more interesting life. So I'm going to read both rows. Okay. Say, do you know romantic couples where one of the partners or both have schizophrenia, someone who got married, had kids, and that kind of stuff? You're asking me if it's possible to get married and become a parent when you have a diagnosis of schizophrenia? Do you know any other people with schizophrenia? No, I guess I met some in the hospital, but they were all in bad condition, and we didn't really talk to each other. My community is not familiar with these kind of things. Even if someone is dealing with mental issues, it's kept secret. People don't talk about it. So you don't know other people with mental disorder, and it sounds like it's forbidden or not easy to talk about having schizophrenia in your community. Yes, not talking about it with anyone is difficult. Actually, the only person with schizophrenia I know is John Nash from the movie Beautiful Mind. Smiling. And how did that movie make you feel? Good. It's a good movie. But I'm not sure if I can cope like him. And I can't ask him how he managed or succeeded. if you met someone with schizophrenia, what would you like to ask? Everything. Is it possible to manage work, romantic relationship, and family life? How do you do it? It seems that you feel you can learn about your diagnosis and about coping with it from other people's recovery stories. Yes, that might give me strength, hope. Okay, so that was the first phase of the therapy. And during this phase, in clarifying Emma's agenda, the possibility of integrating psychoeducation and marriage, and the process began. In the following session, I offered Emma psychoeducation tools adapted to her needs, wishes, and metacognitive level. Okay, what we did with Hebrew, and try to translate, we read together the psychoeducation module of the illness management and recovery program. And we watched together 2 short movies on the subject of coping with serious mental illness. And one of them dealt with the self-stigma, and the other, I will explain about it in my example, next slide. Okay, so during the process of learning facts about the diagnosis, Emma was encouraged to reflect about her and others' mental states and using the core elements of the merit. I will try to give an example. The 7th element, stimulation of self-reflectivity and understanding the mind of others. While watching the TV show, you can't ask that. People who cope with serious mental illness. You know this format? It's a TV show that aims to offer insight into the lives of marginalized communities and break down stereotypes while answering the questions people are afraid to ask. So in this chapter, there were 5 or 6 individuals that cope with the serious mental illness, and they shared the story and answered some of the audience questions that were sent ahead. Okay, so let's go to the self-reflectivity. Her baseline level was 3.5. Meaning that she was partially able to define her emotional states, but the range was quite narrow or limited. And so while we were watching this, while we were processing the experience of watching the TV show, we were trying to expand the emotional range, exploring conflicting emotions, such as shame, guilt, and fears, next to gratitude and cautious optimism regarding the speaker's condition and regarding her current condition. And all of the time, it was a kind of integrating what she think was familiar, what was different, what she knew, what she didn't know, what made her feel better, what scared her, discussing all of that. And regarding the understanding the mind of others, her baseline level was 2, meaning that she was able to represent others as having autonomous thoughts and feelings, but she did not recognize specific mental activities and emotions. That's something very general. Okay, so here, while we reflected on the experience of watching the TV show, we tried to enhance curiosity to the way Emma perceived the mental states and feelings of the speakers in the movies. I think it was a good starting point, maybe even easier than discussing the next step, which was her friends, her relatives, and sometimes when it was possible, using the merit element of the therapist's presence and how does she perceive me. Okay, so what happened next in the final stage of our therapy was a new agenda. Once Emma became more aware of her own thoughts and feelings about her diagnosis, a new agenda for the therapy evolved, and she asked, I want to talk about my diagnosis more freely and openly with others. And she chose one of her sisters and two friends. So the final stage of therapy focused on her mastery with regard to self-disclosure of her mental state, how to do it, how to make it in a dialogic way herself. Like she internalized, I hope, our metacognitive dialogue about it. And so it doesn't need to be a speech that she comes and tells and explains, but a conversation in the terms that she chose. Okay. And so I would also like to share some of our results regarding metacognition. A reliable change occurred in the mastery subscale. It increased from mainly passive or avoidant strategies at the pre-treatment stage to active behavioral coping strategies at the follow-up assessment. And other results were improvements in quality of life and depressive symptoms. Regarding the narrative and her illness perception, I hope you can see it became more complex. It began with, I am 32 years old, single and schizophrenic. And here it sounds like a beginning of a story, right? I'm a single, 33 years old, live with my parents. I had a normal childhood until at the age of 26, I became sick and my life changed. Okay. And yeah, also less controlled by the diagnosis, severely, and here it comes to 50%, 50 or 80%, try to estimate it. There is more hope and more willingness to achieve personal goals, such as driving and dating. Okay. Here I want to share some of our ideas from our experience on how to integrate psychoeducation into merit. And so first, exploring the current wishes and needs, that's always a good idea. And here specifically, we want to understand, is there a curiosity regarding the diagnosis or the symptoms or recovery stories? And also not something general, and try to understand what exactly interesting is it. Can I be a creative person? Can I be an independent person? What is the wish of my client here and now? And the next step is choosing specific tools according to the client's needs and metacognitive level. And then the dialogue. It's sharing facts about the diagnosis, but also talking about what those facts meant within the context of the unique life of the individual. And yeah, again, integration of facts and experiences and emotional processes. And the purpose is making sense of symptoms in the context of a subjective life story. For example, Emma was able to see how immigrating to Israel as a young child and seeing her parents struggle to adjust made her choose to toe the line, sometimes at the expense of attending to her own wishes and emotions. She was also able to see how the breakup of her engagement, which is a violation of community norm, caused an outburst of suppressed feelings, including unresolved anger that could be connected to the hostility she felt toward her family during her psychotic episode. Okay, so what we try to do is to understand her story and what happened to her, and not define all of this psychotic episode as something that is out of control and out of reach. I think it helped. Okay, I'm going to conclude with some clinical significance and consequences. What we think is that subjective needs combined with metacognitive level can serve as a compass for creating person-tailored, integrative, effective interventions. And creative and flexible integration of psychoeducational tools can be especially meaningful among individuals with severe mental illness. Yeah, here I remind you the beginning of my talk. often they don't receive an appropriate delivery of the diagnosis for many reasons, and there are some studies that explore this, and one of them recently published. And last, metacognitive dialogue regarding the meaning of the diagnosis can promote a more complex and adaptive self-narrative. And that's it. I would like to thank you for your attention, and I would also like to thank Professor Ilanit Chasson-Kayon and Professor Polaisaker for inviting me to speak here today.
I mean, I guess I really appreciate these presentations for many reasons, but I mean, amongst the foremost are that Libby and Simone, you talk about how to integrate meaningful interventions in a way that doesn't distract from the basic principles of merit, and moreover, really even promotes them. And Simone, you talk about working with people with severe personality disorder and what it means to think with them about themselves and their bodies, to take a self-compassionate stance. And Libby, obviously, you also talked then about what it means to help people make sense of what this is, that how the world sees them. How does the world make sense of the challenges they're facing, and how can they describe them in a way so that they can fit into the world? And I think this is often very much for us as a group, sort of the key issue, which is how do we do the things that we're comfortable doing therapeutically? How do we choose and select things that are integrative in ways? And so I guess, I mean, I have a question for both of you, which is I wonder to what, if you have thoughts just about the general process of integration and how you came to examine the particular things that you've examined and shared with us today.
Okay, Libby, it's too much polite, so I go first.
Actually, Ilanit, that is here, was, I still remember that I was wondering what to do, what is, it was a mutual idea, it was a dialogue between us that enabled us to be creative and flexible and finding the way. And she always told me, ask her what does she want to learn? Does she want to watch together? Does she want to watch? I offered her some things in a very, I hope, respecting way. And yeah, I think that what helped me was that we had a dialogue about it as a team.
Just like to elaborate on this, I think the main thing that Libby is emphasizing is that it was a dialogue between her and the patient. It wasn't we decided to do psychoeducation. She asked the patient, after the patient expressed their wish to learn more, Libby asked her if she wants to learn together, and what will be the way she'll prefer. She wants to read together something, to watch a movie together. And Libby also explored how the patient felt with Libby's suggestion. It was very intersubjective, all the process, and in a very dialogical way.
I think these are, I was just going to add that I think these are important ways of making someone's experience regarding their diagnosis more meaningful and more rooted in their story. So that's obviously, I think, would go over a lot better.
I think for me, one thing that I found myself thinking about as someone who is sort of learning how to supervise from a merit perspective, I think that these, both of these presentations kind of helped me like come up with ways that I think would be digestible to people who are learning merit and who are maybe used to kind of utilizing some of these techniques like psychoeducation or mindfulness and those sorts of things, and like explaining how you can still use those from a merit perspective and how you can kind of maybe add on just a little bit extra of like exploring what those things mean to the person and really using those in like a dialogue versus just sort of teaching the person. And so I think that it was really helpful to sort of think about that as you guys were talking for me.
Yeah, kind of a similar thought. I mean, I think that the way you describe, Libby, the integration of psychoeducation makes a lot of sense in the merit framework, and you can clearly see how the enrichment of the person's idea of themselves follows from that that interaction. I think what I see a lot of around here is using psychoeducation as some kind of corrective tool to like get the person to agree with the professional. And it's typically like a front-loaded thing. So we'll do psychoeducation at the beginning until they have agreed with our diagnosis, and then we'll go on and do whatever after that. And it does seem like a pretty clear distinction of, possibly even covering some of the same territory, but done with such a different spirit that you can imagine quite different results. I guess I am left wondering a bit, I don't know if you have thoughts about this, about how or when this type of approach would be indicated or not if someone really disagrees with the diagnosis, someone who has poor insight or sort of adamantly rejects the diagnosis that was given to them in the hospital, and maybe what kinds of modifications you would take to this kind of approach in those cases.
Yeah, thank you for that. Actually, we had, I'm not sure if the majority, but many of the individuals, the clients that came to our trial, one of the questions that you all know is, how do you describe your condition in your own words? And I don't think that the majority said schizophrenia. They had many, sometimes other words, and sometimes they disagreed with this diagnosis completely. And I think I would not offer them psychoeducational tools if they are not interested or curious and will not find it helpful. Maybe making sense of their experiences and symptoms, but without having them having them have a diagnosis, a word that they don't find useful. I would not do that.
I think it's you went with the client's agenda, and if it's not a client's agenda, Jay, so we won't do that. We do psychoeducation if it's something that comes from the client.
And in circumstances that was not part of any peer support, or did not have anyone. His family did accept him, but accept her, but was not able to talk about any emotional or mental distress. It was needed. I wanted to have a comment for Simone. I think that it was very helpful for me that the compassion can be also for the, if I understood correctly, for the wish of the schizoid personality not to be in touch with others. Like it is a kind of a dialectic kind of thing, because if I read the paper, and if I understood at the beginning, you use the compassion for the client, and I wanted to ask, how can it become something that they can give to others, compassion to others, when it's so complicated and they are so threatened by the presence of others or by the pressure to contact other people, right?
Yes, no, in the two cases series paper, we are just we are in the editing proof phase. We present two clients. One, he is a man, 90 years old man, and he was more, I would say, stereotypical in the sense that the aim was shared goal, shared agenda within the therapy was not to increase the social network. In this sense, we use techniques, also experiential techniques, aimed at better understanding, for example, the parents who were trying to force him to increase the social network, but the goal was not to accept the pressure, but rather to understand this kind of pressure, the meaning for the parents to have this kind of pressure in order to increase the communication, to meta communicate with them, because one of the practical goals that emerged during the therapy was to find a job that was consistent with his idea not having a huge social life. And it's what he found. On the other case, she was a woman, and she had a relationship, and so she had somehow a more complex inner life than the previous client, and in this case, it was important for her to understanding how he had automatisms based on her schizoid mechanisms, aimed at defending by detaching from the others. But at the end of the day, it came out that she was compassionate, in the sense she was trying in his dysfunctional way to protect the partner from her characteristic that she herself perceived as dysfunctional, as maladaptive. And so she thinks not to deserve a relationship. And so at the end of the day, by increasing the self-compassion, she was capable to access in a more healthy way to her capacity to be compassionate with her clients. Again, she didn't get a huge increase in the social network, but she found a more healthy way to experience the existing relationships she had.
Yes, one thing that also strikes me as we think about this as integrative practice is that in both cases, there's also reflection on the experience of the intervention as well. So not only is it jointly agreed upon that this is what you're interested in, like in that, I think the wonderful comment, Melanie, that you made, where you talk together about what is it you want? What is it we can learn together, which is perfect. But then also there's joint reflection on that process of learning, and it's an ongoing and responsive set of things. So Simone, you talk about trying out different interventions, but then being open and willing to accept that there may be an unexpected response to them, and you may change up what you're up to. So it seems like these become then a springboard for ongoing reflection. And it makes me think about some conversations actually Emil and I have had about as he's tried out different interventions, that regardless of how much that intervention makes sense, it becomes some opportunity to think together about the experience of the person with the intervention and even their experience in treatment in general.
Yeah, no, I totally agree with what you are saying, especially in the experiential techniques. There is this idea that since some therapists have discovered the experiential technique, it works for anyone. And so it's like the Dharma for all movement that gave the rise to the mindfulness movement. So I guess in psychotherapy, the less is more is always a good principle to be reminded, and that the other is so it's like quite consistent with merit, that is it's the client leading the game, not the therapist somehow. So we have to have a good wide range of alternatives in order to adjust to client's agenda.
I was just thinking about perhaps some of those situations when we're doing psychoeducation, when something about education about a diagnosis, that diagnosis then becomes the explanatory construct for every kind of, that's kind of Kelly's term, but an overpermeable construct, meaning that it explains that the client's now using that to explain everything that's going on in his or her life. And sometimes it's a useful step, but how do we deal with it when it becomes sort of an over-encompassing sort of conceptualization or model that takes over at least from the client, the clinician's perspective, takes over the client's mind, that this is the most important thing, is that their diagnosis, it's sort of capitalized, and it's like the most, it's the core central organizing principle the person's using at that point to kind of organize and put their life together.
So yeah, I think that our experience was that it was not the diagnosis that was the most important thing, but the recovery stories. That was what was interesting, to combine symptoms and diagnosis with the way people cope, hearing and understanding narratives. Like she did want to understand what is the condition, but not to stay in this level. It was always going along with the recovery stories and interest in recovery as a very personal and very unique kind of process. Would help us not to stay in the phase that you were afraid that we can be stuck on.
You kind of use it as like a step toward praxis or toward doing something, as opposed to
always stimulating mastery, not just staying with the diagnosis, but also how I cope with challenges, going back, finding interesting work, going back to the dating, or even how to disclose my mental illness so I will feel less alone with it. It was always together with this kind of
so it's interesting too, because so what is the product that comes from the intervention? And then it doesn't become the answer and then the story is over. Like now we have world peace because you've learned self-compassion or accepted your diagnosis. But it becomes, like, as you say, Reed, and as you also say, Libby, it becomes a way to deal with the world, or I guess for me, the phrase that comes to mind is how to get life right. So how do you relate to people in a way where you're finally sort of getting it right, where you're able to connect, to relate, and have an ongoing sort of response to the world? And maybe this dovetails with other stuff that like many of us have been talking about a lot lately, which is this idea that sort of the core problem is more about how to have a responsive, ongoing life rather than to just get to the next step or to get the prize. And in each of these interventions, the person is better equipped to respond to the world and to deal with what emerges before them, rather than they now have the thing they need. Perhaps this is another key sort of feature of our own integrative work.
Yeah, I guess I think it also has been my experience, to your point, Reed, that frequently by the time someone makes it to my office, they've already kind of embraced that stance. So rather than as an outcome of a psychoeducational approach, it's an outcome of many years of being bounced around the system, that they've sort of inhabited some sort of sick role that usually has some kind of stigmatized notion of what it means to be diagnosed with schizophrenia. And I've certainly had conversations with people that have some kind of flavor of psychoeducation in those cases. I think part of the trick there seems to be, if someone comes in quite demoralized and embracing that, like, I'm here because of schizophrenia, I'm on disability, it seems a bit more of the like sharing my own thoughts when I notice those things, and not necessarily responding to an agenda that they wish to have a more enriched idea of the diagnosis. So it does seem to me like, I mean, I find it to be a bit of a tension there. But I think it follows a similar kind of spirit that both like Libby and Elnid have commented on in trying to, and Simone too. I mean, I think I might introduce some idea and ask the person if that's something that they'd heard of before, and if they would want to know more about it. They want to know what I think about the diagnosis.
Yes, I guess it's also part of the element of agenda in the sense that personally, I usually prefer to use personality / dimension constructs that I find more consistent with daily language, so less stigmatizing, perhaps to explain. But I also found, and I guess, and one of us, sometimes people that want to deal with a diagnosis, no? They want to know what's going on with me. I have read a lot of stuff around, please don't avoid my question. It is, what do you think? What I'm diagnosed with? And so, personally, I would prefer not to write to the point because I don't like to use categorical diagnosis, but sometimes I have had some clients that directly and repeatedly ask me to, please, I want to have a clear-cut diagnosis. I want to deal with. Yes, obviously we discussed about this request, but also I felt not comfortable in avoiding that, and so especially in the domain of personality disorders. So, and again, my way is to always come back to listen to the clients, define a shared agenda, and then include also the diagnosis into this process.
Well, are there any other thoughts about sort of the idea of integration in this work and sort of the task for us as a group to be able to sort through that complex set of issues?
Maybe we can have a kind of, a library of all kind of integrative approaches that were already made. I know that Ilanit, you also had the agency before action and integration of behavioral activation into merit, right? And I'm not sure, maybe there are other ideas, and maybe it can be useful to have some kind of approach to all of the things that were made or will be made using an integrative framework.
Well, for me, replying to your question and the way you, and following your comment, Libby, I think we're just, basic theories on integration that organize types of psychotherapy integration talk about 4 models. And I think we are using it's my impression, maybe other people here think differently. I think it's a assimilation approach, because I think we have merit as a main approach that we work with, and we keep the elements and we assimilate into it other interventions when needed. But we always keep the elements and we work in the spirit of merit, if I can say that. And we assimilate into it other approach. So I think it's the third approach that when Norcross defined the 4 different models of psychotherapy integration, I think this is the third one, the assimilative one.
We're at a good spot to wrap up. I really appreciate the 2 excellent presentations. Thank you, Simone and Libby, for your outstanding contributions. Thank you, everyone, for joining you. And we're looking forward to a presentation on merit as adapted for group in our next merit meeting.